Surgery for occupational spine injury. Who you see is what you get. Costs related to occupational back pain increased over 65% from 1996 through 2002. Specifically, surgery for occupational back injury accounts for approximately 21% of these costs. Even though there is little literature evidence that spine surgery improves patient outcomes, surgery rates have increased dramatically since the 1990s. A study published in Spine in 2012 examines one possible explanation for this increase: who the patient sees first after an injury. It's entitled Early Predictors of Lumbar Spine Surgery After Occupational Back Injury, results from a prospective study of workers in Washington State, published in Spine in 2012. The researchers used the Disability Identification Study Cohort, or D-risk data, to examine factors that might relate to a higher use of spinal surgery for occupational low back pain. The D-risk study identified participants prospectively through weekly claims reviews from the Washington State Department of Labor and Industries State Fund, which covers approximately 2/3 of the state's non-federal workforce. The D-risk data comes from 3 sources, including administrative claims and medical bill data, medical record review, and worker self-report in telephone interviews. Some of the factors analyzed included age, gender, Hispanic, non-white, and Caucasian status, higher pain ratings, and injury severity, opioid use within 6 weeks after the first medical visit, workers' perception that their job was hectic, employer offer for job accommodation after injury, various psychological factors, rural residence, history of previous back injury, and workers with shorter job duration. Generally, the data indicated that 9.2% of workers with compensation for temporary total disability had lumbar spine surgery within 3 years. Total temporary disability was defined as at least 4 days of no work. 137 had a decompression procedure, 6 had a fusion procedure without decompression, and 31 had both. Here we can see when workers had surgery. About 3% had surgery in the first 30 days, and then around 20 to 25% in the next 2 months, the next 3 months, and the next 6 months, for a total of about 77% in the first year, then 15% in the second year, and 8% or so in the third year. Multivariate analysis revealed 3 predictors of surgery: baseline Rowland-Morris Disability Questionnaire scores, injury severity, and the type of provider first seen for that injury. More likely to have surgery within 3 years after injury were those with a higher Rowland-Morris Disability Questionnaire score, if there was a greater injury severity, and for those who first saw a surgeon for the injury. Lowest odds for surgery were if the patient was younger than 35, female, whether they were Hispanic, and those whose first visit for the injury was to a chiropractor. 42.7% of workers who first saw a surgeon had surgery, in contrast to only 1.5% of those who saw a chiropractor. Also important to note is that surgery occurred more frequently with patients who had a diagnosed radiculopathy with reflex, sensory, or motor deficits. 32.8% received surgery. But even for those with radiculopathy and no neurological deficits, the rate of surgery was 24.7%. So just as important, what didn't the study find or confirm? Instead of relying on predictors such as psychological factors, it appears that the obvious factors of higher disability and severity of injury, when taken together with which healthcare professional is seen, is perhaps more predictive of at least the outcome of surgery. Based on the results of this study, the non-modifiable factors that influence surgical rates are disability and pain, gender, and ethnicity. The only factor that can be influenced and changed that would dramatically decrease surgical rates is who the patient sees first after injury. Based on the results of this study, that must be a chiropractor.